Okay, welcome everybody. Thank you for joining us specifically on a Sunday evening. I know for some of you East Coasters it's pretty late, so thanks for spending your Sunday evening with myself and Dr. Williams. My name is Joel Ramirez. I am the Director of USMLE Complex and Medical School Tutoring at Med School Coach. We also have Dr. Dustin Williams with us today, who will be sharing his wisdom and some of his experience on several years of educating and creating online med ed, which is one of the, if not the most successful medical education online resource available right now. So the title of our presentation is going to be Maximizing Your Clinical Year to Succeed on Step 2 CK. This will be a mostly 2 CK webinar, and we'll kind of touch on how you can integrate preparing during your core clinical year for success for Step 2 CK. There are a few things that I'd like to orient you right off the bat. We have a question and answer part of the webinar. We also have a chat part. So if you type in the chat, that's kind of an active chat. And if you type questions into the Q&A, we'll essentially keep those, and towards the end, we'll address them, or if they're particularly relevant to our topic that we're discussing, we'll talk about them right away. So if we go on to the next slide, we will not only be talking about preparing for Step 2 CK, but we will also be doing Mythbusters.
And with that, introductions, me first. Why should you listen to me is basically what this slide is about. I was a clerkship director, associate program director, a practicing hospitalist at Baton Rouge General, which was a satellite campus for Tulane University's LEAD program, and then also for AUC most recently. I have resigned that post to work full-time on online med ed. But in my time as an educator, I've worked with students and residents, both those who have failed and that I remediated, and then also those that have helped succeed. And I'm a lifelong educator. I left clinical practice so that I could focus full-time on online med ed. I'm the founder, co-founder, and the lead educator. I'm the guy in almost all the videos. And so even though this is hosted by us, and of course we're trying to sell you something, we thought it appropriate to say, hey, we're trying to give you some good information, but the intention is to sell you stuff. And that is indeed our conflict of interest. Joel?
Great. My name is Joel Ramirez. I'm the Director of USMLE Complex and Medical School Tutoring at Med School Coach. Med School Coach is a company that provides essentially help in getting people admitted to medical school, and also provides MCAT tutoring and USMLE and Complex tutoring. So my disclosures are, I run our medical school tutoring program. I've been a tutor for Med School Coach for 3 years, and I've been a master tutor for 1.5 years.
All right, so I usually like to ask the audience, we don't have an audience, to ask, but Joel is going to send out a poll, I think, asking people, what year are you in school? What you here for?
So you can see the poll pop up on your screen. Go ahead and choose one. We'll give people about 30 seconds to a minute to submit an answer, and we'll go ahead and share them afterwards. Okay, I still see a few people filling out their answers. All right, so it looks like most people are third-year medical students, which makes a lot of sense. Looks like we have some folks who have graduated and probably trying to take Step 2 CK, but it sounds like the majority of folks are about to either start their clinical year or are in the middle of their core clinical year. Excellent. And then I have one more question for you guys, which is, have you taken Step 1 yet? So a lot of you are in third year, but there are now a lot of kind of hybrid curriculums in which you take Step 1 after third year. How many of you have taken Step 1 yet? Okay, so no surprises there. It looks like the majority of folks have taken Step 1. I imagine that the almost 20% are students who go to schools who now kind of have a new hybrid curriculum in which they take Step 2, take Step 1 after their core clinical year. Great.
All right, so the target audience is actually in the room. Excellent. So I'm presuming those people who answered I'm a third year are starting or getting ready to begin their clinicals, or maybe have just started them. And that's good because there's some things that you did that probably made you successful in basic sciences, going to class and studying for step 1 that you do not have available to you as you move forward. So all the things that you figured out and made you successful, you have to lose those and get some new ones. And that's what we're here to talk about today. So first off, what's the difference? Step 1, step 2, right? Step 1 is all about mechanisms, how things work, how things break, and how medicine can fix them. And generally that means at the cellular level, or at least at the level of the organ, not at the level of the person. Step 2 is going to be familiar content, but it's going to be taught with a different emphasis, and you're going to be evaluated on that different emphasis. And the emphasis is on management, making the diagnosis, knowing which diagnostic step to pick, and knowing which initial intervention you need to choose. More about diagnosing and treating. Something else is different about step 1 and step 2. Schools usually give their students dedicated time off to do step 1. They don't. Step 2. Put it to the audience, you don't have to answer because obviously you're not here next to me, but when I say autonomic nervous system, think about what you're thinking about right now. It's probably spinal cord, some lines going off, right? G, S, AC, CM, PKA, GQ, IP3 DAG. Yeah? If you're done with your clinical years, you're going to say, yeah, beta 1. If you give someone a beta agonist, your heart rate's going to go up. A beta blocker will go down. That's the difference between mechanisms and management, right? It's going to be a vigorous shift from what you're used to. The devil is not anymore in the details. It's not about knowing all the mechanisms. It's about making the right choice. And it's actually good because the USMLE, medical licensing exam, step 2 is supposed to assess your ability to know a little bit about a lot. So I know that people throw around the word illness script. I'm going to define it for you, what it actually means. It's the story that a disease takes. And I just try this out on people. Most people have heard this before. 74-year-old guy, crushing substernal chest pain, radiating down the arm and up the jaw. Pale, cool, diaphoretic, sense of impending doom. MI. Now that's the patient side of things. What you spent 2 years or more learning was the pathogenesis behind that disease. Atherosclerosis, foam cells, hypertension, diabetes, LDL, right? You need to know that as a doctor, because as a doctor, you need to know more than every other healthcare provider. But then there's all this other stuff underneath it that actually lets you practice that patient. What step 2 does is it carries the illness script further than the history, right? That same person, pale, cool, diaphoretic, sense of impending doom, substernal crushing chest pain, right down the arm, up the jaw, hypertensive, diabetic, smoker, no S3, non-proliferative, non-positional, non-tender chest pain. EKG shows no ST segment elevations. Troponins are not elevated. Now, those of you who are done internal medicine, your rotations, you're like, yeah, I'm following you. All right, and then Mona Bash, good. All right, what about clopidogrel? Plavix load? Full dose heparin. Now I'm starting to lose people, all right? And the idea is that the illness script for step 2 is not the whole thing, right? It's only going to be the initial diagnosis and the initial management. And the illness script becomes more important in identifying patient diagnosis and treatment, and sometimes follow-up, and less on pathogenesis. The challenge to step 2 is that it asks you, the learner, to know about every specialty. As soon as you go into residency, you forget all the other things not your specialty. And the reason for that is we want people specialized in the thing that they're going to see. Right? When you are a medical student, you will be seeing real disease. Right? You're not going to get the classic presentation, 0 standard deviations from the mean. But what you need to know and what you'll be tested on is exactly that, 0 standard deviations around the mean. And when you specialize, what you give up is broad breadth, right? You don't have this wide amount of knowledge you need because you don't only have to know your specialty. But as you go into experiential training, you then begin to see the 1 standard deviations around the mean all the time, uncommon presentations of common disease. And then you see the rare diseases and the rare presentations that don't make any sense. But you have to know what that thing is in the middle, which is why the USMLE tests you on it in order to realize, hey, this is the way it's supposed to be. These 2 patients, even though they're not similar at all, are just variations around the mean. And if you know that, then going on to practice medicine becomes a lot easier. So that's a little bit about step 1, step 2, and illness scripts. We are here to talk about how you're going to maximize your studying. And there's a 4, step 2. The cool thing about clinical medicine is that if you prepare for the test, you prepare for life. This is the first time it is actually going to be true. Now, separate from what I'm about to talk about, when you have a patient in your clinical rotations, it's been assigned to you, you better know everything about that patient and the details of that disease. Read the whole up-to-date article, right? Because your attending knows a hell of a lot more than you do, and they're going to keep pressing you until they find something you don't. And since you only have 2 or 3 patients, you should know a lot about them. For everything else, do not do that. For everything else, remember, you only need to know the diseases, 0 standard deviations from the mean, always the common presentation, always the normal, no variation. And for those of you who don't know, step 1 and step 2 are not allowed to throw curveballs. If they give you information, it's trying to guide you to the right answer. ABIM, right, internal medicine boards, they can trick you all they want because you're supposed to know it really well. You're supposed to know a lot of diseases at step 2, but they're only 1 presentation. They're not going to trick you or get you, I got you. So what you have to do is balance 12 hours a day in the hospital, knowing a lot about your patients and fulfilling the expectations of your attending, and simultaneously fulfill your expectations of doing well on the test. Because what they're going to be doing is their job, right? They need to get the work done, and they already know all the stuff that you know, and they want to bring you up where they are. It's called tacit. They forget that you haven't seen a patient with cardiac disease yet, while they're on the cardiac floor and see 20 every day. So do the things you're asked to do by your attending, impress, do well on rounds, know your patients really well. And then also have a plan, study the things you need to study to do well on the test. Good news also is you've got shelf exams at the end of each of your questions. Many steps, all right? Dedicated only to that small amount of content relative to the rest of the USMLE Step 2, and sort of like practice along the way. So the phases of learning. This is probably what you did for step 1, right? You went to class for 2 years, 1.5 years, and then your school said, you know what, step 1 is so important, we're going to give you time off for it. So between the end of class and the beginning of clinicals, you had a dedicated study period. And what we have right here is the phases of learning spread out over 8 weeks. The blue is study phase, the learning phase, where you actively take in new information. You spend time, you invest it, and you review along the way. But this is acquiring new knowledge every day. The green is the taper phase. And the taper phase is where you stop learning, much like a competitive athlete, a swimmer, trains for 3 hours a day, pushes it to the limit every day during the training phase. When the big event meets about 2 weeks out, you get in the pool, right? But you do it easy. The point is you're not trying to make any additional gains, but you don't want to lose what you lost either. And you're preparing for the meet, the big day. So too must you use your brain in the same way. Focused, aggressive training during the learning phase. And in the taper phase, take it easy, but don't lose it. The learning phase looks something like this, right? And in a dedicated study period, you do all day, right? Flashcards in the morning, and you schedule in breakfast, lunch, and dinner around doing lessons and reading this material, doing this many questions. And in this point, you do questions to learn the material, not to test yourself. You do it Monday to Friday, and then on Saturday and Sunday, the weekends, you take it easy. Review or rest. I recommend that someone does a review day on Saturday, reading all of your notes or whatever book you're using in order to keep track of stuff. Try to get through the whole thing, everything you've studied up to that point, not just that week. And then on Sunday, actually take a break. Now, most med students don't know how to do that, but make sure that you're trying to actively continually learn. You need to let your muscles rest, your brain, so that you can start the next week being aggressive again. You get to the taper phase, and what you want to do here is prepare for the big day, right? Blocks of 40 questions, 7 if you can do them, but that's a little bit much. Turn off tutor mode, turn on timed mode. See what it's like day to day. When do you freak out? When do you get exhausted? When do you need to take a 30-minute break? Build in to your daily routine exactly what it's going to be like on test day. Eat the same thing, get up at the same time, take breaks when you recognize what you need to do. And if anyone else tells you to do anything other than what you feel during this phase, tell them to go fuck off, because they're going to tell you how to do how they're doing it. And the way they're doing it is not better if you're figuring yourself out. The last day, and I stress this to everybody, but people refuse it, take 2 days off before the exam. If you can't do that, review. Now, that makes a lot of sense, right? People will probably recognize that. You may have done something similar. I didn't say what resources to use in that learning phase or in the taper phase, so there's different ways to do it. But you don't have that anymore, right? In clinicals. You're not, and actually, since step 2 isn't important, which we'll get to later, schools will not give you dedicated time off. So how the hell are you going to do this? Well, I'll get to that in a sec. Oh, I see. They don't have my thing in here. Great. So what you should do instead is, rather than do that in a dedicated period, what you should do is do it concurrent. And concurrent means you're learning something every day, and you're doing it concurrently throughout the year. What happens is you do one learning piece a day. And we'll talk about what that is next, the slide I just showed you. Do one lesson per day. And over the course of your clerkship, you'll get all of the lessons you need done for your clerkship done. At the end of the clerkship is a shelf exam. What most people do is spend the first week trying to figure out what resource they should use for that clerkship. Because up until recently, every clerkship had the best resource, and it was different. Everyone spent the first week or 2 trying to figure it out, which means you're already 2 weeks behind. And then you would aggressively study all learning phase, no taper, take the shelf, knowledge bulimia, and then you'd be gone. You need to start that cycle over. What you want to do instead is, just like we had during the learning phase, study time, review, or rest, you want to do that on a grand scale. At the end of every clerkship, it is not the end of that content. You just review everything you've done up to that time. Now, you take that Friday night off, right? But the idea is just look at everything again to re-engage that information. Keep track of whatever you're studying. And where the learning phase and the dedicated time was as many lessons as you could per day, in the concurrent style, it's only 1 per day. And the idea for that is it lets you have time to do your clinical work and also have enough time to get through all the medical knowledge stuff. At Online Med Ed, we have our paradigm. Right? It's called PACE, Prime, Acquire, Challenge, and Force. And what we recommend people do is find resources that work for you. Well, yeah, of course, what we actually recommend is use our stuff. The videos are free. There are different learning modalities that are available: books, lectures, QBanks, and flashcards. We've sort of done them all, but let me run through the resources really quick. Books. There are 3 kinds. There are the skeleton books, muscle, and skin. The skeleton books are the review books, right? They're outlines, they're quick annotations. If you haven't studied it yet, no idea what it means. But after you studied it, it's good for bringing up reminders. The second is the muscle book, or the reading book. This is paragraph prose, right? You actually have full sentences, but it's not in depth, doesn't have all of the pieces. The third is the reference book, right? And that is the book you should never open. It is Harrison's for internal medicine. It was Big Robbins for pathology. You should not open that book. You should only have a reading book. And you notice what's not on there is primary literature. Get out of that habit, right? What you need to learn is the classic presentation of common disease, 0 standard deviations from the mean. Lectures, video lectures, however you go, you're going to be forced to endure your clerkship lectures. You have to go to them, right? Get credit, check a box. But then come to online med ed because our stuff's free and the best that's out there. Third is the QBank. I recommend people get 2. Right? What you want to do is use one in the learning phase. And so what you want there is for very well-written questions and well-written explanations that follow the MVME Writer's Guide, giving explanations for why distractors are wrong and what would change in the vignette to make those distractors right, not just giving you little blurbs. But then you want a second one for the taper phase. You want one that looks like the exam, that feels like the exam. It does not matter what the answer explanations are. It doesn't matter how many you get right or wrong. All it does is simulate that day. So I recommend use 2. Lastly is flashcards. Do not learn from flashcards. Do not memorize. Step 2 is cannot throw curveballs, but they can put in buzzwords that will throw you off. So if all you've done is studied with flashcards, they'll catch you. All right. So these are your resources. And ideally, you put them together and you would have a thing that you could go to every day. At Online Med Ed, PACE, Prime, Acquire, Challenge, and Force is notes, video, questions, flashcards. Books are P, lectures are A, QBank is C, flashcards are E. And we have it laid out by clerkship first, and then by organ system or subsettings if it's too big. And the idea is do the things that are for that clerkship using a paradigm that works. And then because you learned it so well, not just memorized it, but learned it, when you're done with the shelf, it stays there. And so when you're done with your rotations and you're ready for step 2, what you can do is take a really easy rotation. Radiology, 9 a.m. to noon. I got to do that, 6 weeks of that. Darn, all right. So I had to put those 3 hours in, and then I made that my review time or my taper time, right? So I've actually backed up family medicine, which was a 6-week rotation, 2 weeks of radiology. Family medicine, where I was at in rural Louisiana, was actually quite nice. Friday, Saturday, Sunday to myself. So during the easy rotation, I crammed everything that I had already learned up to that point. Right? I reviewed it. It was fast to do it again because I had already spent so much time learning it, and I had learned it so well, it was easy to put it together. And during radiology, I tapered, and at the end, I killed it. And then this is just a general piece of advice. Nobody knows what the right thing is. Nobody. And if you listen to somebody else, take their recommendations, it may not be right for you. And then you take a recommendation from somebody else. Uh-oh, which one do you use? Now, this happened to someone I was with when I was in med school. She listened to everyone else and got started on 9 different things, but only finished 10%. Didn't do so well on step 1. But she figured that out, that was the problem, and did what everyone else was doing and for step 2, and then now she's a surgeon. Right? So you know what's right for you. You're going to find the right things. But what most importantly is make a plan, make a schedule, stick with it. And during the clinical years, it's got to be slow and steady.
Great. Awesome, Dr. Williams. I think we have 2 questions that I think are pretty pertinent that I think we could address now before we move on to our next segment. One is, what if you're in an integrated clerkship model where we don't have blocks for each specialty? They take all their shell exams in 1 week. I do know of similar curriculums. Mm-hmm. How would you prepare for your shells in that context?
I hope it's like the ones that I've seen where they give you 3 times as much time, right? Like if they do medicine, peds, and OB, they give you, that's 3. So math is hard. They give you the year basically, right? So our rotations at Tulane were 8 weeks long, AUCs were 12. So if you're in that integrated curriculum, hopefully they're not giving you 8 weeks of integrated curriculum, take all 3 shells. I don't know how to help you if that's the case. But if you have a normal amount of time dedicated, they just happen to be together, make a plan, stick with it. It's a little bit more like doing STEP, which is a little unfair, which is probably why they're doing it rather than piecemeal. But I haven't had a really good answer for that. But if you have more time, use more time. If you don't have more time, demand it from your school.
Yeah, I think, you know, the slow and steady thing is even almost more important here. You just have to be more diverse in what you're studying. So you can't commit only to surgery for 4 to 8 weeks and then only to pediatrics for 4 to 8 weeks. You're going to have to be doing surgery, pediatrics, and family medicine over, you know, 3 or 4 months and then take all those shelf exams at that time. So it's just got to be slow and steady. There's another really great question here that I think is probably pertinent for pretty much everyone here, is how do you aggressively prepare for shelf exams when you have a hectic schedule that starts at 7 a.m. and ends at 7:30 p.m.?
Yep, you have to have the right resource that gets you that teaches you efficiently and effectively, and you have to find time to do stuff during the day. You may be at the hospital for 12 hours, but I know that you're not actively doing stuff for 12 hours, right? It is okay to study. It is okay to disappear from not from the building, but from the hallway. You just need to tell your resident that you're doing it. So there's 2 answers to that question. The first is 1 lesson a day with a resource that makes your study time efficient and effective. You have to do that. And you have to study every day. People say read for 30 minutes, bullshit. You have to do a section. And however you divided up your sections, whether it's blocks of questions or if it's a lesson on online med ed, whatever the case may be, you need to make sure that that thing gets done. And if it is that busy during the day, find time for yourself to work on something, and it has to be something, right? It can't be on rounds, right? And when that happens, you should let the resident know that you're doing it and where you're going to be, what your number is, because you want to be present. If you're not present, you won't get to do things. If you're not present, people won't like you and they won't give you as good of a grade. But there's a balance. You just standing there for 12 hours, not studying, not contributing, is going to hurt you. So 2 things: stick with it, get a plan, stick with it. Most clerkships are achievable 1 lesson a day. Medicine is not, especially if you have anything less than 8 weeks. You have to get to what you can get to. And if anything else, you have plenty of time. If it is medicine, try to do it last. That way you can actually like build up, so you can, like, with your extra time on peds, you can start knocking off some medicine cases, getting ready for it.
Yeah. Yeah, absolutely. I mean, I have to second all that. And it really is slow and steady, and then an added efficient. So if you take a shuttle to, you know, if you live in a city and you take a shuttle or a bus or a train to your clerkship, then while you're sitting on the train, do something that could be easily done with, you know, minimal attention. So answer a bunch of questions, which you'll review later in the evening. Try to make a schedule, like just an hour every night. Like, commit to yourself, I will read an hour every night except for my day off, and just don't not do it. Just stick with it. And, you know, an hour every day or 2 hours every day, you know, is, you know, 12, 14 hours a week, and you multiply that over the amount of weeks you have in the clerkship, and you're going to get a decent amount of studying in. It is a challenge, but you're not alone in that challenge. I have 2 polls for you guys. I think the first one is, I'm going to launch it right now. It's asking, have you made a plan to study for your core clinical year? So I know most people in attendance are 3rd-year students. Have you put together a plan? Have you thought about this? And have you kind of put something on paper or on the computer? A few more people are still answering. I'll give it another second or 2, or another 10 to 15 seconds or so. Okay, so it looks like the majority of folks, about 65%, have not made a study plan yet. So I think that this is a particularly timely webinar, which I think now it's mostly the beginning of the clinical year. Maybe for your folks who start earlier, maybe towards the middle, but it's not too late to do this. And also, you're like, the people who didn't show up to this are going to answer no, right? You guys are proactively learning about this, all right? And just to put it in perspective, I didn't have a plan when I started doing clinicals. I did that 2-week thing. Like, I tried to find out what resource is the best one, which book is the best one, and that scrambling every time with no plan cannot happen anymore. There's too much to know, too much to do. So I was with you. Don't worry. Yeah, and it's make a schedule. You're trying to minimize your pain, especially during the 3rd year when, you know, like you said, you spend all day in the hospital and you're constantly put in weird, awkward situations as a med student, and then you come home, the last thing you want to do is study. So it's important to kind of put something down on paper and stick to it. I have one more poll for us, which is just a quick poll. Have you ever worked with a tutor? Great. So it looks like the majority of people have never actually worked with a tutor. So 72%. It didn't actually let me vote, but if I could have voted, I would have put yes. I definitely have worked with a tutor before, particularly in college. Great. So let's go ahead and move on to our Mythbuster section. I want to thank everyone in attendance because you all provided us with these myths. You guys submitted myths when you registered. I went through all of them. We had about 70 registrants. I went through all 700 registrants. I went through all 700 and I picked, I think, 8 or 9 that I thought were particularly pertinent. You would be maybe not so surprised to know that a lot of these myths were, a lot of people submitted the same one. So I think that these are common things that medical students hear. And so we're really excited to sit here and kind of talk through each one and either confirm them or dispel them. And if you have questions, go ahead and submit them to the question and answer. If you want to chat live, your microphone does not work. We can't have 237 people talking over each other, but you can you can type in the chat, and I'll try to look at the question and answers in the chats while we're talking live as well.
All right. Myth number 1, step 2 CK doesn't matter. I've heard this a lot, and especially back in my day, where deans would actively prevent people from taking step 2 if they got the good step 1 score, thinking that it could only hurt. And I just got through talking at most schools provide dedicated time off for step 1 because it's so important, and they don't for step 2 because it's not important. Well, this is definitely a myth. It is absolutely important. It matters. It matters to you. It matters to you because it's a chance at redemption or confirmation of excellence. Now, if you're a road scholar, R-O-A-D, going to Durham, right? You're going to submit your application with everyone else who got a 260 plus on step 1. So you thrown in there a 270 plus on step 2, boom, confirmation of excellence that sets you apart from the person who didn't. For others, it may just be a confirmation you're not a board's fail risk, right? You don't have to get 270s in order to get into residency. In fact, so I'll talk about that in just a second, right? But if you have a score, you want to show consistency, right? As long as you did well, above average, do it. Getting above average is actually easier in step 2 because there's so less detail, right? There's so much more to learn. But it's, again, a way to confirm that you are as good as you think you are, or as good as your step score says you are. The third is a chance at redemption. Now, if you didn't do well on step 1, there is the opportunity to make it up in step 2. Most people won't tell you that. Now, there are going to be some road programs, name brands, right, that if you fail or have a below a certain cutoff on step 1, they're not going to look at you, right? You don't want to be there anyway, right? That's prestige. That's not for you. At Baton Rouge General, we actively pursued people with below average step 1 scores, but above average steps 2 scores, because we knew that other programs would screen those people out, and those people were more likely to come to our program. At Tulane, there's a little formula WES has for internal medicine, right? And everyone gets numbers put in. It's based on your interviews and your step score. There's one box for step score. Which one goes in there? Whichever's highest. Why is that? Because step 2 matters to programs. The worst thing that can happen to a program in terms of their numbers is a board's fail, right? That's what the numbers they have to report. So what they want to make sure is that you are not a board's fail risk. They do that because the board exams are multiple choice exams by looking at your performance on the step exams, which are multiple choice exams. And if you do well on the steps, you're probably going to do well on your licensing exam. Med schools don't want you to fail the step either. So they look at your MCAT score, which is a multiple choice test, right? So what they're looking for is not, this person is so amazing at medicine, it's they're not a board's fail risk. And the reason why both Tulane and Baton Rouge General do this, put in the higher one, because step 2 is the only objective measurement of your clinical acumen, right? All your letters are inflated, right? All your grades, whatever, right? But that is a test. It is a test. It's a multiple choice test. It tests your ability to take multiple choice questions, yes, but it's the best thing we've got. And it has a bunch of rules set to it. No curveballs, only affirmative answers, only one right answer. But then it makes it the best assessment a program has. So doing really well on step 2 says that you're going more likely to be a better resident, because knowing that balloon degeneration and Mallory bodies is a sign of alcoholic hepatitis doesn't help you take care of the drunk in the ER. Neither does getting the answer right in step 2, but it's one step closer.
Great. I mean, I have to mirror that too. Step 2 CK is now just as important. If they did a survey actually of program directors across multiple specialties, the NRMP, which is what they do the match and all that. And they essentially showed that step 2 CK, I think, was a 4th or 5th most important thing they looked at, and it was above the personal statement. So whether that is good news or not, these program directors generally think these board scores, even step 2 CK, are more important than your personal statement. So step 1 was the number 1 most important, and step 2 CK was either the 4th or 5th, but still very important.
And I think that's because people screen out, right? When we got all the applications from ERAS, what we would do is say, so we'd set standards, foreign medical grad, this score, American medical grads, this score, and then we wouldn't even receive the applications. So that's probably what that comes from. We'll use it as a screening tool. And I bet they're not even looking at it. But I wouldn't be surprised, because you definitely get that number gets put into, not letting it sit like a calculation, but if you got a good score, you bubble to the top.
Great. So we're saying this myth is dispelled. Step 2 CK does matter.
And number 2, 2 months, 2 weeks, number 2 pencil. That's 2 months for step 1, 2 weeks for step 2, don't study for step 3. Because step 2 CK now matters, this is definitely a myth. You learned a lot of stuff in basic sciences. You have to learn the same volume of information in your clinical years while you're doing clinicals. So spending 2 weeks only will not provide you with the score you want, right? Because everyone else on average is doing the same thing, right? And so if you don't do at least the average amount of work, you're going to perform below average. But the 2-week thing is interesting, because that's how long taper phase is, right? If you've been spending your entire year in clinicals learning the right way, learning for retention and understanding, not just memorizing to regurgitate on a shelf, when you end clinicals and you have your step 2 scheduled, you may only need the 2 weeks to prepare. In step 3, well, you should probably work a little bit harder, especially if you want to do a subspecialty. People now look at step 3 as a differentiator if you're trying to get into fellowship. Again, I think this is bogus, but it's what people do.
Yeah, this is definitely a myth. I heard this a bunch of times, and so I expected to study for 2 or 3 weeks for step 2 CK, and it was going to be easy, and that wasn't the case. So definitely not true.
Yeah, number 3, USMLE scores define your value and potential as a physician or a person. These are multiple choice tests, right? They assess your ability to take multiple choice tests. You have to prepare for them by doing multiple choice questions and full multiple choice tests. But even though they are highly ranked on whether or not you get your thing downloaded, or whether or not you get an interview, or whether or not you get in, it is just an assessment of your board's fail risk. To you, this is irrelevant. To the programs, it's a big deal. You can practice medicine excellently and still do poorly on a multiple choice test. But the numbers that people report, boards fail, that's what they care about. The good news is that once you graduate from medical school, the game changes. It's not about getting honors. There's no test. There's no win or lose, do better than anyone else. There's only doing good, practicing medicine. And so regardless of how well you do in these tests, as long as you make it to the next step, you can still do good work. You can still help people. You are still intelligent. You got into medical school. You can't not be exceptional to have made it this far. Just because the test says something doesn't mean that's you. It's just your ability to take multiple choice tests.
Yeah, completely agree. This is dispelled.
Dispelled. Myth number 4, if you scored low on step 1, it is impossible to score high in step 2. Ooh. Good news is that the things that you study in step 2 is what you went to medical school for. Everybody thought what they were going to get into was actually what you get into in residency. No one thought they had to work 16 hours a day, 7 days a week, learning microbiology and biochemistry. No one gives a shit about biochemistry unless you're a PhD in biochemistry, in which case, good for you, you made the switch over to being a real doctor. Right? So the stuff on step 1 is hard, it's nebulous, it doesn't make sense, it's uncomfortable, and it's written by PhDs, which you're not trying to be. So yes, it is. I do believe people have a ceiling, right? I did a study at Tulane when we assessed people, what was the greatest predictor for their step 1 score was their MCAT score, and a bunch of the stuff has been published. So some people have a ceiling. Some people are not going to be able to get a 280, right? Either you lack the commitment or the ability to remember it all, which is fine because 280 is like 3 to 4 standard deviations above the mean of medical students, right? Being an average medical student is exceptional. But step 2 CK is about the stuff that you wanted to do, right? Picking the drug, reading the film, picking the right test. So it's more natural to take step 2. And even though it's not a reflection of what actually happens in the hospital, it's a reflection of what you learn, right? And those things are easier to retain because this is the medicine you wanted to do in the first place. And it lacks the pathogenesis details that were so confusing and conflicting. So with the right study plan and the right materials, you absolutely can improve your step 2 CK score. The surgeon I was talking about earlier went from below average to above the standard deviation, 1 standard deviation above the mean, step 1 to step 2, just did it the right way. Joel, you probably see this a lot too, huh? People come to you.
Yeah. So I think there are often situations when students come to us since after, scoring not as high as they want to on step 1, and they're interested in doing something like plastic surgery or dermatology or something really competitive. And I think we really use this opportunity as a chance to kind of redeem yourself and show that you are able to do this. I think, like Dr. Williams said, I think step 1 is particularly challenging because it's really hard to make a connection between foam cells and people. And I think people went to medical school to work with people and to help people, and you end up spending your time learning the Krebs cycle, and sometimes it's really hard to make that click with kind of your meaning in life. And so, I think step 2 CK is really a wonderful opportunity to do better and to improve on that step 1 score and show that these programs that you are capable and able to do things.
Yeah, I agree. It is hard for international medical graduates to score a high in step 2 CK. Well, you do.
I think this is particularly pertinent because a lot of questions we've had in comments have been, as international medical graduates, or medical students, is this a pertinent? Does it apply to us? So I think particularly timely.
Yeah. So you have to speak English, right? Like it's an English exam. I vacationed in Aruba and I just like dabbled in what it would be like to get a medical license to practice there. It's in Dutch. And I don't speak Dutch, so I will not be a doctor in Aruba, right? So you do need to speak English. It is not hard for an international medical graduate who speaks the language and is able to know the medicine to do it well. It is hard if you think that passing your exam in your country qualifies you for passing the exam in this country, right? Practice patterns are different. The incidence of disease is different. Europe, it actually was at my time at Tulane, we'd have ICU grand rounds, right? And I called him the Italian stallion, this old Italian guy and this young up and coming guy from Manhattan. It was like America versus Europe. And ironically, the Italian guy always cited the American literature in ICU, and the American guy always cited the European, and they literally always were the opposite, right? Like literally 2 academic physicians with good evidence behind them, and they were both always opposed to one another, which means that if you're practicing somewhere else or studying somewhere else, you can't count that as studying for the USMLE. The USMLE is the United States Medical Licensing Exam. It's not how to practice medicine. It's the standards of practicing medicine in the United States, written by the United States Medical Board. So it's hard if you do it wrong, but if you do it right, I don't think so.
Great. Awesome. Dispelled. Well, semi-dispelled. I guess depends on the situation.
The things that you can help yourself with can be fixed. Right? If you don't speak English, it's kind of hard to pass. That's 6. You'll learn everything you need to know for, oh, I didn't even finish saying that. You'll learn everything you need to know for Step 2 CK.
This is a very common one.
Yeah, abso-fucking-lutely not, right? For internal medicine, you do 3 years of internal medicine, and then we say you've done enough internal medicine to know internal medicine. You as a medical student do it for 8 weeks, and the residents carry 20 patients. You carry 2. The words are experiential. They're very important. Medicine is experiential. You have to see patients at the bedside. You have to touch them. You have to listen to them. You have to read the films. So that practice is good, but you only get what you get. You only see the patients that are in the demographic area that you have. Like when I started at the General, we were in the indigent population, so I saw a ton of HIV. As soon as we moved to the fancy hospital, I saw a lot of CHF and AFib with RVR in 90-year-olds, right? And on the cardiac floor, where we dedicated students to the cardiac team for a month, all they saw was heart, right? So what you need to do, you need to know your patients, you need to know your diseases, right? Get the reference book, read the up-to-date on the 2 patients you want. But then you have to do the things that are expected of you to be learned that you're not gonna see. I had an MEN2B as my first patient in internship. I made the diagnosis, good for me. And at a conference, all of the UCSF guys were like, "You've seen one of these? Can we make this our special case?" And I was like, sure, it was my first, right? You need to be able to answer MEN syndromes on the shelf and on Step 2. You will not see one. Now that's a dramatic example, of course, but the point is you will not know everything for the test by being on the wards. And that's actually one of my biggest gripes with one of the guys I worked with, who thought that doing more work accounted to doing more learning. Practice does not make perfect. Perfect practice makes perfect. And if your goal is a score on an exam, you need to be studying the right way.
Yeah, I think this is a huge myth that I was told so many times and still hear people sharing. It's just simply, I think Dr. Williams mentioned, you want to participate in the team and know your patients and know as much as you can about your patients so you can participate in their active patient care within the hospital and answer questions about, their pathogenesis and all these things that you'll be asked. But, I spent 8 weeks on internal medicine and I carried like 3 or 4 patients at a time. You're not going to see much really as far as numbers of diseases. And you really need to go home and spend some time reading about other things. So know everything about your patients. I think one nice strategy is when you're in the hospital, maybe spend that time reading about your patients and treatments and diagnoses. And when you go home, flip open the book or flip open online med ed and think about things differently. Think about things on a broader scale. Think about things, preparing you for a big picture and preparing you for the exams. This is a huge myth. Don't be fooled. It's insufficient for you to prepare for Step 2 CK or yourselves.
And you'll hear this from clerkship directors and attendings, not just like other medical students. The people who don't know are giving you bad advice. This is not the case. All right, myth 7. It is easier than Step 1 if you do it right, if you study the right way.
This is also a very, very common myth. I probably saw this like 40 or 50 times that you guys submitted.
It definitely is easier for the reason we talked about, right? Like it's more in tune with what you wanted to do. It's more to do what you thought medicine was, unlike Step 1. Step 2 CK isn't easy. It's just more familiar. And it is easy in the sense that they don't throw curveballs. Remember, you only have to know the 0 standard deviations on the mean, the classic presentation, the common presentations of every disease, because you have to know every specialty. Any one illness script is easy. It is. You can know the whole thing. Now go learn 10,000 of them and not get them confused. It is easy if you do it right, if you study the right way. But I would not think this is sort of the 2 months, 2 weeks things. Do not be nonchalant about this exam. Treat this just like you treated step 1. It is just as important and just as difficult. If you do better on step 2 and step 1, you feel like it's easier, good for you. But don't say that until you've done it.
Yeah, this was very confusing to me. Kind of in line with the 2 months, 2 weeks, number 2 pencil. I think that studying for step 2 CK was easier. It was easier to force myself to read about diagnosis and treatment of disease, but I thought the exam was very difficult. I really felt like I felt the actual exam day was going to be more difficult than step 1, because it's definitely not easier. It's just a little easier to study for. The days feel less long.
And then we talked about this already. Yes, you do. Take step 2 before your ass goes out. I mean, if you have 2 great scores, you are gonna tell you, yeah. I mean, this is true for some, right? If you are going into primary care in rural Arkansas and you have a 250 on step 1, you probably don't need it for step 2, right? If you're doing something that doesn't have any very competitive requirements, you don't have to do it. But more places, even the mediocre tier 2 non-name brand programs, are looking for the step 2 score. And if it's not there, the fact that it isn't there means that you're not on your A game, right? You're not putting your best foot forward. You're not trying to show us that you really care about getting into this residency. It may be because it's how your schedule worked out, but the implication is, why didn't you just get it done? Like, get it done. Like, when you're going to be a problem. So I would say that it has chance for redemption, chance to confirm your excellence, and it's expected now by most programs that you have it and have it visible.
Yeah, a lot of programs nowadays will not rank you unless you have a step 2 CK score. So although you can submit your application, you can get invited to interview, they might love you at the interview, but they will not put your name on a rank list if there's no step 2 CK score. So what that means is the decision makers and people making the list are going to see your step 2 CK score. So you really don't want to get into this thought process and then, either rush at the end or not do it. Just think of it far ahead of time, prepare for it adequately, and just as you would for step 1. But a lot of programs nowadays will not rank students who do not have step 2 CK scores.
And so this is actually, this is a really good myth, because 10 years ago it was true, right? And it has definitely changed. So people who are in practice now were students when it was like that and have not noticed the change, so continue to start the thing that they know, right? People actually know, right, because I did it, can give you a different perspective. And also, don't forget that you don't have like 3 months off from October to December. Interview season is like ridiculous, where you burn a bunch of money and do a bunch of traveling. You can't realize, oh, I'll just get that step 2 CK done during interview season. I'll still have to study for 2 weeks. If you're that far behind, it ain't going to work. All right.
Yeah. So I heard this myth. I think since I went into surgery, a lot of my mentors were, chief residents or towards the end of their residency. But a surgical program most of the programs were 7 years long. So this was when they applied, which was 7 years ago. And a lot of people said, don't risk it with step 2 CK. Don't even take it until the next, until after ERAS. And then I kind of talked to other people and then learned that I was going to need it to be ranked. And so then it's just think about it ahead of time and do it on your terms instead of on a kind of last minute or someone else's terms. One great question that I've seen come up once or twice now is what do you do if your last rotations before step 2 CK are not quote unquote easy ones? So what if you're doing something like surgery or internal medicine on the rotation before your exam?
Move step 2 back. Put it after an easy rotation.
Yeah.
Like you set your exam day, right? Like you build your schedule, just move it.
Yeah, I completely agree. I always encourage people to try to take dedicated study time for step 2 CK, like at least a month. I think as all of you have already experienced, it's very hard to work a 12-hour day and come home and study. And there's a lot of challenges associated with that. So if you know that you did poorly on step 1, or you know that you're a weaker test taker, Or you know that you want to do something like dermatology or plastic surgery or orthopedics, and you need to score really high on Step 2CK. Work with your school to get more study time. Most schools will have some way that you can do this, some way for you to schedule an elective or schedule study time. But if on paper it's not possible, email somebody, meet with somebody, try to figure it out. It's going to be worth your time.
Or grab a rotation you know is really easy. That's, you know, you can show up for in 3 hours.
Yeah.
But the rest of the day is yours. Right?
No rounds, really not much for a medical student to do, so they'd feel bad to send you home like early afternoon.
And then tell them you're studying for your exam, and they'll be like, "Oh, dude, get out of here!" Right? Like, unless you have like an asshole school and an asshole attending, like you're not, like those both have to happen. You're not gonna. It won't be an issue.
Or you could just bring a computer or bring a book with a flashlight and study in the reading room. Either one works. There's a few questions about DO and the MB OMEs and osteopathic medicine. So I think most of what we kind of talked about was focus on Step 2CK. I'm sure that there are several similarities for the complex level 2. And from my understanding, they're very nearly similar exams, just they don't have the osteopathic manipulation. So I think everything we talked about is pertinent. Just as a plug, Med School Coach does have complex specific tutors. So if you want to get advice specific for complex, we have people who could work with you.
And we have OMM content. So the DOs, I think, just have to do everything the same plus OMM, right? And you have to learn OMM for Step 1 anyway. So the Step 1 and Step 2 content don't change. And the OMM content on the shelves is still the stuff that you learned in Step 1. And actually, Jeremy Pullman, our DO educator, has put together a lesson on here's the OMM that you should pay attention to for your shelf exams.
Awesome. Another good question is, if my first 2 years didn't prepare me well in understanding mechanism, do you recommend spending some time learning Step 1 during like your clinical year or while preparing for Step 2CK?
It's a difficult question for me to answer because the answer is yes, but no. I built online med ed with the understanding that most people didn't get the education that they needed in the first 2 years. And so what I try to do is link the pathogenesis to the illness script. And so if you're going to use online med ed, don't do it, because you get enough of it that you won't have a mastery of physiology, but you'll have the information you need to take care of patients and get the answer right. The whole point of my teaching is not so that you thank me or that you get an award. It's that when you need to make a decision, you make the right one. Understanding is more important than truth. So if you're not already armed with that information, don't go back and try to get it. Move forward and plug it in when you can, right? Because what you want to do at the end of the day is practice medicine. You don't need all that Step 1 stuff to do it. You'll be better for it. And to tell you, I'm going through it now, and I'm having epiphanies left and right? Look at my notes from Step 1. All the words are on the page, but like this is totally new to me because I have the clinical perspective. So if you ever want to go back to Step 1, you can, but keep moving forward because you don't need Step 1 to do the work. And you have the rest of your life to pick up the stuff that you didn't get.
Awesome. There's a question of who would I need to contact to learn about the OMM. So there's OMM content on the online med ed website. And then if you're interested in Med School Coach tutoring, you can, there's information on that on the Med School Coach website as well. Great. Well, we're just about out of time. I want to thank everyone for joining us. I really appreciate you spending your time with us, particularly Sunday evening. I had a lot of fun. I hope you guys found it useful. We try to do it, towards the early part of the clinical year, so we set you guys up for success for the rest of your year. A little bit about Med School Coach is we do offer a lot of tutoring. So if you find yourself in a position in which you need some extra help, or you're struggling on a shelf exam, or you find yourself struggling to make a study plan, we can help with all those things. We help with creating study plans, content, questions. It's all personalized one-on-one tutoring. We're pretty much out of time, so all this can be found on our website. If you look at just medschoolcoach.com, a lot of great information there, very descriptive. You're also welcome to contact us, and you can actually schedule a 15-minute consult with me, and we can talk more about your situation and if we think tutoring will be useful, and if so, how tutoring can be useful. So thank you, everyone. This will be recorded, and put online on the Med School Coach YouTube website. So if you miss something, it will be there. You can watch it later.
And in closing, online med ed, if you haven't found out about it yet, it's free. The videos are free anyway. And also on your dashboard, for those of you who are looking to haven't made schedules, if your rotations are 8 weeks long, you have my static schedules that you can use for each of the rotations that is dedicated to 8 weeks. Those are free too.
Great, everyone. Thank you so much. We'll try to do another one in the next 3 or 4 months and try to share some more of Dustin's Williams knowledge. But for now, take care, everyone.
Have a good night.